person is intoxicated, they can remain in the emergency room at that time instead of going to a facility where they would take up bed space. For that short window of time which we've described.
So, Madam Chair, follow up?
Delegate Levine?
So please explain to me exactly how your bill changes current law on that. I'm sorry, I'm not clear.
Madam Chair, what it does is it says if the subject is intoxicated, they will hold them for 24 hours to allow them to become intoxicated. And so many people that are in this situation, they end up having to find a bed for them. And when they're no longer intoxicated, they don't meet the criteria for a TDO, and then they're released. During that 24-hour period, instead of having them use a facility bed, we're leaving them in an emergency room, for example, or another similar type setting, not taking a bed, which they probably shouldn't be in the first place.
Madam Chair,
Delegate Bell?
I'm hearing something from Delegate Head in response to Delegate Levine. I'm on the same commission. I might. The issue is someone comes in and trying to decide if they need to be taken to the state facility. We already have to give them medical care because the state facilities don't all have medical care. So the first issue is you're going to keep them in the ER in most cases to, if you will, sober up before we send them to the state facility. But by the time they get sober, they actually are no longer really appropriate for involuntary commitment. And we thought this was a microscopic problem and frankly just part of the issue. And no, it's actually a much bigger problem. And we have a 99+% psychiatric bed fill rate right now. We have too many people going in, and we're desperately trying to find ways. We're actually opening another hospital, which is not the long-term fix, but the goal was we thought this would actually free up some bed space from people that don't actually need to be TDO.
That's right.
Isn't that right?
Isn't that true? That is correct. Madam Chair.
I now understand the bill, thank you.
And this is work.
This is the perfect answer to
No,
this.
this actually doesn't change. It includes the language that keeps law, makes clear that law enforcement doesn't have to stay within 24 hours either. And this is going to procedures and implement.
Okay.
But
It does need to go to appropriation for the reports because the right observation.
Got it.
capacity. Drive slowly.
Okay, any further questions from the committee? Did you get any?
Yeah. That answered my question.
Anyone here to speak in favor of House Bill 1452?
Good morning, Madam Chair, members of the subcommittee. Amy Parrott-Seibert on behalf of the Virginia College of Emergency Physicians, and we want to thank everybody for working with us on this. We actually got together with the Sheriff's Association, the Chiefs of Police, Department of Behavioral Health, the Hospital Association, and the Community Services Board, and came up with a substitute. So I think we were all on the same page. I think we really do think, as you guys have all been talking about, this will be a really good step and be able to handle, from a medical standpoint, be able to keep people up to 24 hours to help them become unintoxicated, whether that's taking too much Tylenol, whether that is drinking or drugs, and then if they have an opportunity to then be reevaluated to see if they need to have an actual ECO to go for the mental health services. So we think it's an opportunity to kind of be able to help clear folks and get them into the community services if we need to, instead of having to go straight into the mental health facility. So we hope this will be a good step in that direction. We appreciate everybody's support. So
Okay, thank you.
Mhm.
Anyone to speak in opposition to House Bill 1452?
Good morning, Madam Chair and members of the subcommittee. Deidre Johnson with Vocal. We oppose this bill because lumping together the mental health and intoxication pieces could potentially lead to unintended consequences of an individual enduring a mental health crisis and it effectively exacerbating their crisis because they are being confined for a longer period of time than actually necessary. We absolutely see the benefit with increasing to 24 hours for the population of our substance use peers because that gives them time to detox and then they can be discharged. Thank you very much.
Okay, thank you. Delegate Bell, did you all have any conversation about that with the bill?
The substitute does pull back from the original language. So the substitute to the bill changes the language in 1104 somewhat substantially, pulls back from what we have there and is now drafted to indicate that for the purposes of 1104, mental or physical condition includes intoxication and addresses, I think, some of the issues raised.
Any further questions? Okay, we've heard a motion. I think I heard move to report and refer to appropriations with substitute. Is there a second?
Second.
Right. Alright, so the motion has been to report and refer, to appropriations with the substitute. And, clerk will open the rolls, members will vote, cast your vote. Alright, clerk will close the rolls and that passes 6-0. And Delegate Hope, if we could take a break really quickly, and come back to you. We have two other patrons that are here that aren't on the sub. Alright, Delegate Goditis, if you wanna come on up, and we're on House Bill 1482.
Thank you, Madam Chair.
You ready?
We have amendments. I don't think we're calling it a substitute.
It's just a line amendment.
Okay.
And here are some copies for Delegate Guidance if she needs one, and it's very short, so I'll read it. 1482. Get there real quick. Alright, the line amendment to 1482. One amendment on line 43 of the bill. We're going to strike all of the new language there in subsection D, striking all the new language on line 43, 44, and 45. That removes the language that reads, if the court finds that the criteria are met, the court may, in its discretion, extend the period of involuntary admission for a period not to exceed 30 days from the date of the appeal hearing. So that will be removed from the bill.
Thank you.
Alright, is there a motion on the amendments? Alright, it's been moved and properly seconded for the amendments. All those in favor say aye.
Aye.
Any opposed? Okay, so 1482 as amended is in front of us. Delegate Goditis?
Thank you, Madam Chair. So this has to do with appealing involuntary commitment orders, ICOs. And we were originally trying to do two things. The second thing was we couldn't figure it out so that it was a really good fix, which is, so the amendment chops out our second attempted fix. The first thing we are fixing is that there are two different statutes in code now for appealing ICOs. And our CSB came to us with this and told us that people are very often confusing the two. So the two bits of code, one says, I've been involuntarily committed, but I feel better. And the other one says, I never needed to be involuntarily committed. So the problem is, I'm gonna get tangled up here. Can I ask for?
Sure, do you have testimony?
Yes.
Phone a friend.
She's come on up.
If you could come on up and introduce yourself.
Sure. Good morning, committee. My name is Amy McMullen. I'm an assistant Commonwealth attorney in Loudoun County, Virginia. Okay, as it stands right now, the individuals who are involuntarily admitted tend to appeal their admission, and there are two different issues that they're challenging. One is continued hospitalization, and the other is the validity of the underlying hospitalization to begin with. The way 37-2A21 is currently written, it doesn't delineate which proceeding that the individual is contesting. Essentially, so what happens is the way that it's currently written, if an individual is released from hospitalization, there are two kind of collateral effects of the way the statute is currently written. First of all, an individual who has been released from hospitalization, that medically has been released, runs the risk, if they pursue their appeal hearing, of being recommitted. And so they can be re-hospitalized just by pursuing the appeals hearing. When the only reason they're pursuing the appeals hearing to begin with is to contest the validity of the underlying hospitalization. The other collateral effect is there are individuals that are released that decompensate, and they are, recommitted, and that's appropriate. But also, if an appeals hearing is dismissed because the inappropriate statute is not followed, those individuals have the ability to essentially walk out of court and walk out to a gun store and purchase a firearm. The only thing that allows you that bars the purchase of a firearm for somebody in a mental health crisis at that stage is getting to that involuntary admission hearing and either having mandatory outpatient treatment ordered or having hospitalization ordered. If it is dismissed simply because the wrong statute, the wrong standard is applied or the wrong issue is addressed, then those individuals have the ability to walk out and do that. So there is a benefit for clients who are involved in the process, because they have the ability, if they're really better, not to get hospitalized again and to appropriately have the appeal dismissed, but it is resulting in appeals being dismissed simply because the wrong issue is being attacked. This bill clarifies which standard should apply. As it stands right now, 37-846, which is the one that deals with the challenging the validity of the underlying commitment, is basically never utilized, because it's not, there's no way to direct to it.
And it should be used, because if a patient, that would get it off the patient's record. If it's shown that they never needed to be involuntarily committed, then that is not on their record.
And
I'm sorry, there is a second line amendment we need to make to the bill to complete what you wanted to do in the first one, and that is in the bill, if you look on lines, we have line 43, in subsection C, if you look on lines 39 through 41, to restore the stricken language as well.
I've heard a motion to accept the second amendment and second it. All those in favor say aye.
Aye.
Any opposed? Okay, so we have it with the two amendments.
Two amendments.
Madam Chair,
Yes, Delegate Bell.
I think it's easiest to staff. Sarah,
Yes.
Ms. Dan, if, so what she's saying is that there's two ways. One is to appeal the I never should have been found. Which number is that? What, is that the 846?
846 is I never should have been hospitalized to begin with. That's in 37-846.
Okay.
And 821 is designed to challenge existing commitment or existing hospitalization.
Sorry. And then, ma'am, if you could tell us again the sections to where you're saying I'm better now, which is that?
37-821 is someone who is contesting existing hospitalization.
Okay.
So that would be I no longer need to be in the hospital.
I see.
Yes.
Okay.
I'm in now, I want out, versus I shouldn't have been there in the first place.
Okay, what you're suggesting, by different paragraphs, it indicates clearly which road you're traveling down. Is that
Correct. As it stands right now, the practical implication of the bill is the way it's written is that the judges don't have any guidance of which standard should be applying. So they are applying the incorrect standards essentially. Or they're applying a standard that doesn't apply to the situation that actually exists.
Any further questions from the committee?
Yeah, but
Okay.
just making sure, again, maybe for staff, so some of the language we're striking in section A includes things like appeal shall be filed within 10 days from the date given priority over all other pending matters in the court. Do we wanna strike that?
It's all in
It's
B.
in B.
It
Everything
just moves
struck in
down
A
the
goes
block.
down to B.
No, I understand, but
Except
since we are,
for-
Delegate Bell.
I'm trying to make sure we don't strike stuff, I mean, so,
It simply moves it from one spot to another, to make
I'm
clear
sorry,
that.
what's left of A? What does A mean after this is done? A is the should never have, or that's the I'm better now.
This whole section is the I am currently committed and you should not be.
I'm sorry, okay, so there's a whole nother section that
Yes.
says I'm better now.
There's a whole, this is the I'm currently committed, I'm better, I should no longer be in custody. The other section, that's 846, says I have already been released, but I'm challenging the validity of the underlying
Okay, so we don't need to,
decision.
there's nothing we're doing messes that up.
No, this is just clarifying how this section works.
All right, anyone here to speak in favor of House Bill 1482 as amended? Come on up.
Good morning, Madam Chair, members of the committee, Jennifer Basin with the Virginia Association of Community Services Boards, and we're here to support this legislation.
Bruce, good morning, Bruce Cruiser with Mental Health America, Virginia. We certainly supported the change that the delegate made, and it appears that this will certainly ease the process and clarify individual rights, and we appreciate that. We support it.
Thank you, Madam Chair, members of the subcommittee. We want to thank Delegate Goditis for making the changes and we support the bills amended.
And who, I'm sorry.
I'm sorry, my name is Melissa Charles-Gibson. I'm with the Disability Law Center. Thank you.
I'm still learning, thank you. Okay, anyone here to speak in opposition to House Bill 1482 as amended? Any final words, Delegate Goditis?
Just that we have on here, so we heard from Virginia Association of Community Service Boards, National Alliance on Mental Illness, Virginia, NAMI, Mental Health America, Virginia, and AB, we have heard from all those that they are in support. So,
I move to report the bill. Let's find it.
As amended?
As amended. That's what I said, as
It's been
amended.
moved and properly seconded for us to recommend reporting the bill with amendments. Clerk will open the roll and members will vote, please. And that motion passes 6-0. Clerk will close the rolls.
thank you, Madam Chair.
Thank
members
you,
of the
and
subcommittee.
Delegate Adams.
Is yes and
Oh. All right, the committee will be at ease for just 1 second. Alright, we're back in order, and this is House Bill 1026. Delegate Adams.
Thank you, Madam Chairman, members of the committee. House Bill 1026 is a proposal to amend the statute on involuntary admission and mandatory outpatient treatment orders, specifically Code Section 37.2-817. And it simply removes one of the elements that is currently required to be proved by clear and convincing evidence to allow a special justice or judge to grant mandatory or to order mandatory outpatient treatment, and that's the first one under subsection C1 if you're looking at 37.2-817, and specifically it's the requirement that it must be shown by clear and convincing evidence a person has a history of lack of compliance. And the reason this is introduced by me, I have not appeared at these hearings, so I'm not intimately familiar with them, although I'm an attorney myself. Close to my jurisdiction is the Southern Virginia Mental Institute and the SOBA Health System, where these hearings are held, and an attorney who practices there quite frequently has alerted me to this as a barrier to releasing more people who would otherwise be eligible for release as an alternative to their involuntary detention. And just as a practical matter, I'm told that that's what's happening. And so I've asked that he appear today to speak to you a little more specifically about how this comes up in hearings, and if that
Yeah,
pleases
sure.
the committee. Okay, Mr. Money.
And if just for us, if you could say your name and who you're with one more time.
I'll just stay here.
Yes, I'm, Madam Chairwoman and members, I'm James Martin, attorney from Danville, Virginia. I've been defending mental health commitments for about 10 years there. And one issue that has come up that our special justice has mentioned and I have noticed is the issue that Delegate Adams has mentioned. You have to prove to get mandatory outpatient treatment, or MOT, you have to prove that they have been committed twice within the past 10 years, and basically that they have messed up. Now, you just happen to find out about it because it's not supervised, so the only way you can find out about it is they somehow mess up or they come back in a third time. We have had people occasionally and sometimes frequently that are clinically ready for discharge according to the mental health professionals, and the judge only has two options. This comes up in under C, subsection C and subsection C1, because sometimes Under C, they're just getting ready to release the person to MOT, and under C1, it's like the judge wants to do it at the original commitment hearing or recommitment hearing. But the judge right now, unless they can prove those priors, only has two options: keep the person in or let them out with no supervision that's being monitored. So I think sometimes they are kept, and I know sometimes they are kept in the facility because we're afraid we let them out, they're not eligible for MOT, and maybe you even have a prior from 11 years ago, or sometimes whether they have prior commitments are hard to prove. We don't have access to the NCIC or we just sort of talking to doctors about whether they've been committed twice or the CSB finds out. I just don't see the logic behind the thing that they would have to basically mess up twice to be eligible for this, and I think it does harm in some cases in that they're keeping people in that could be released, or they're letting people out with no supervision that's monitored. I think it would also be a simplification of, you know, the rather complex system. Is one more thing that we have to explain to a mentally ill patient, which we have a great deal of things that we have to explain to them, all about the MOT and how, well, you can't really do it because we can't prove that you had the two prior commitments, and sometimes they don't even remember if they did. So that's why I urged this bill, and Delegate Adams put it in. If there's any questions, I'll be glad to try to answer them.
Thank you. Does the committee have any questions for the testimony? All right.
Madam Chair.
Yes, Delegate Bell.
Just trying, this is a complicated section of code. I wanna make sure I understand which moving part we're toggling. So this would not require special magistrate, this would not require them to do anything. It would make them eligible for MOT.
They could do it, but right now they cannot unless they had two priors. In no way would it require the judge to do this, either under C or under C1. It's always discretionary with the judge, but right now the judge's discretion is limited if we can't show the two priors.
And the limitations on the current would be, I'm sorry, Madam Chair.
Yes, Delegate Bell.
The current would be inpatient or release without conditions. This creates the third.
It creates a thing which only exists in a limited way now because it's so restricted because of the two prior commitment requirement. It really often cannot be done. Now, I've seen, I've seen it done by substitute people that, you know, they just don't follow the law, but our special justice follows the law, and I'm not complaining about that, but, she's not gonna do it unless, it's authorized by this body.
Okay, I'm gonna ask clerk excuse me, I'm so sorry. Counsel, if she can just reiterate some of the pieces of what the bill is actually doing.
Yes, so currently, a person who's involuntarily admitted can go one of two routes. One is to be involuntarily admitted to an inpatient facility. However, several years ago, we changed the law to say that if we can serve those individuals on an outpatient basis, we'd like to do that. So the second option is outpatient. It's an involuntary outpatient treatment with a court order, a plan, and some penalties for failure to comply. There are three ways a person can end up in a mandatory outpatient treatment situation. One is at the initial involuntary commitment hearing, the options are available and that person is immediately referred to mandatory outpatient treatment. The other two ways a person can end up in mandatory outpatient treatment is following a period of involuntary admission. So one option is that when the initial involuntary commitment order is entered, it is for a period of inpatient followed by a period of outpatient. Both are included in the initial order. The other option is that a person is involuntarily admitted to an inpatient facility, and at the time that order is going to expire, a group of individuals that are set out in the statute can ask for a subsequent period of outpatient treatment. So those are the three ways one can get into outpatient treatment. This bill is only addressing the situation in which a person has been involuntarily committed to an inpatient facility and is either by order immediately going to outpatient or a new order for outpatient will be entered. Currently, those options are available only if certain criteria are met, one of which is the person has a history of lack of compliance, and we explain why it's within the last 36 months. This bill removes that one criteria so that it will expand the option of outpatient treatment for people. Currently, there are people who may otherwise be candidates for mandatory outpatient treatment following inpatient treatment who cannot go that route because they don't have that history of compliance that meets the requirements of the code. So it would allow more people to be transferred to outpatient treatment rather than remaining in the facility.
And the prior commitment is within 3 years. If I said another years, that's incorrect. It's within 3 years or 36 months, the current requirement.
Delegate Hope?
Chair, I'm wondering, in those situations where the judge doesn't have the option to order an MOT, what usually happens?
Well, in our court, they're usually kept in or recommitted. So in some courts, they would let them go. I mean, the judge has the option, but they would let them go to unsupervised treatment, and you just happen to find out that they messed up later. Hopefully, it's not too severe, or a suicide or something like that, or a violence. I mean, I think they're reluctant to release in the Danville area. They're reluctant to release these people without some kind of a supervision if they were on the fence like that. Other places, they may be letting them go unsupervised more.
Delegate Adams, did you have something to add to that?
Well, I did. I just wanted to make reference to the analysis in the fiscal impact statement that maybe bears those numbers out statewide. It says under number 8, second paragraph, this legislation may increase the number of people admitted to MOT. Currently, there are between 300 and 350 individuals admitted each year. That's contrasted against a number of over 25,000 adults and children subject to a TDO. So, when I spoke with one of my local CSBs about this legislation, they were initially had some reservations because they did not like the idea of eliminating the opportunity for folks to be released without, or to demonstrate their compliance. But when I explained that, I think the idea as well, the practical options are being kept, or this. I think they kind of have a different perspective of that now. I mean, I don't want to speak for anyone, but that's the situation.
Thank you, Madam Chair, but that's exactly where I was going. If we're turning out with this provision in the code, more people are being involuntary committed because this option's not available, I think that's a problem. And something, a good reason to take a look at this section of the code.
Any further questions from the committee? Okay.
Move to report.
Anyone in favor of House Bill 1026 can come forward? If you could state your name and who you're with, please.
My name is David Fitzgerald. I'm a member of the Arlington CSB, and I'm a family member of a patient. And I also happen to be on the MOT work group that did not address this particular bill, but when I read about the bill, I was interested in it because essentially what it's trying to do is say, if, as a patient, you meet the criteria for involuntary commitment, so you already have to meet that fairly stringent criteria. If you meet that stringent criteria for involuntary care, then you also now have the opportunity to have an MOT wrapped around you for when you are released from involuntary care into outpatient treatment. So before you had to have this strict twice before having been involuntarily committed. So you've already said the only way you can get mandatory outpatient treatment is you have had to go twice through the revolving door of being voluntarily cared for in the previous 3 years. Now we're saying if you meet criteria, this bill is saying if you meet criteria, that means you are ill and in need of care, then upon release you can be treated under a MOT that gives you every opportunity to be treated on an outpatient basis. So I support the bill from Delegate Adams.
Okay. Anyone here to speak in opposition to House Bill 1026? Come forward if you'll state your name and who you're with.
I'm Madam Chair, members of the subcommittee. Bonnie Neighbor, speaking for VOCAL, the State Mental Health Consumer Recovery Network. In general, we don't support mandatory outpatient treatment because it for some folks, creates sort of a learned helplessness, that I'm no longer able to make good decisions for myself, and it makes some people get worse. I understand, I've heard from folks who say it's made their family members better in the moment or in the year. And so I don't wanna ignore that testimony too. My concern with this bill is it's just a broad stroke paintbrush that all of a sudden we're assuming that everybody is going to be non-compliant, so let's apply this piece right here, assuming that you need extra supervision, when most of us don't. When I was released from the hospital for psychiatric conditions, I did not need extra supervision, and I flourished because of the responsibility that I had in my own care. I think I'm not unusual in the case. So Vocal does not support this piece of taking away, looking back at the history of noncompliance before just assuming that everyone is noncompliant.
Duncan Hope?
Thank you, Madam Chair. Bonnie, I just want to ask you a question.
Mhm.
If what we're finding that when this option's not allowed, that judge orders additional time for voluntary inpatient commitment, isn't that a better option than what the delegate is trying to propose here, outpatient?
Well, I do think that the least restrictive care is always going to be better.
Yeah.
So I think there's a nuance in there that we're, in an effort to provide least restrictive care to folks when possible, I think we're setting some folks up for failure and saying, well, I know you're gonna be non-compliant, so I'm gonna apply this. I know you're gonna be non-compliant. And I look at the learned helplessness and the studies around that. I think we're setting people up for not flourishing, for feeling like a mental health patient that needs this extra support. They can't make decisions for themselves. If I don't have a history of that. If I do have a history of that, maybe. And I definitely, as you know, would support outpatient versus inpatient care when possible.
Thank you.
Hello, my name is Jennifer Spangler. I am speaking on behalf of myself as a person that would be directly impacted by this. My personal concern is that forced treatment, non-compliance, it's harmful for me. It's hurtful. I get into a hospitalization situation and they give me whatever the provider on call, his favorite or her favorite cocktail is. And so I'm given medications that completely go against me. I have no choice. So I have side effects of hallucination. I've had side effects of, not being pregnant but experiencing engorgement. And you're in a forced situation. So I know you all would anticipate that the services being good are well. I'm here to tell you they're not. My healing comes when I get home, not when I'm in treatment. I get back on my regular medications. I head back to, my normal routine, which allows a lot more healing. I also think this punishes people for things that are out of their control. Recovery is a complicated and multifaceted process that involves many providers. And if you're forcing people into treatment, there's not a lot of communication that's going on. And furthermore, I think that forced treatment, for myself purposely, it lengthens recovery. Because again, who actually recovers fully in a hospital for any medical illness? They really don't. So it also increases cost. I'm gonna need further services from my outpatient providers after this treatment to get my head right. I think that it also, sorry, I'm just reading notes, and it will deter individuals from seeking solutions on their own and in a timely manner. And I also think it creates an institutionalized mindset that maintains a crutch on emergency services in non-threatening circumstances. So definitely prefer a community outlook and moving away from forced treatment.
Thank you.
Madam Chair, members of the committee, I'm Colleen Miller from the Disability Law Center of Virginia. With respect to Delegate Adams' bill and the other MOT bills that you're going to be looking at this morning, there's really a wide range of opinions about how effective MOT is, how appropriate it is. But I think that there's one thing we all agree on, and that is that the current system is enormously confusing, is poorly understood by practitioners, by the courts. It's really poorly understood by consumers and their families, and Disability Law Center would urge a much more careful approach to making these changes. Perhaps asking the Deeds Commission to do a study, or supporting the work that's being done out of the University of Virginia right now, looking at this, tweaking at the edges of this, I think has the potential to make it much less understood, much more confusing, and much less effective. With respect to Delegate Adams' bill in particular, one thing that you all are kind of forgetting about is that there are discharge plans for every individual who leaves a hospital. And there's every chance that they will succeed if the individual is willing to cooperate with it. So the options are not hospitalization or forced treatment. There is the option of a discharge plan that the individual can participate in. That too may be poorly understood by the courts. That could be one of the problems that we're facing here, is that the courts see that there's only one option or the other. So we would urge a much more careful approach. We believe the MOT system needs complete overhaul, that it's just really not being effective at all. Thank you.
Good morning, Madam Chairwoman, members of the committee, Jennifer Faison with the Virginia Association of Community Services Boards. And I will say, not to get ahead of the committee and its work, but you all are going to see a number of bills on this topic this morning, and each one of them serves to change a small portion of the MOT statutes as they exist now, which were put into place more than a decade ago. And in agreement with my colleague from the Disability Law Center, it really is probably time to take a look at them comprehensively. And when we look at the kind of the panoply of MOT bills that are going to be before you this morning, most of them have some sort of consequence that could be interpreted as punitive towards the individual, without really getting at the meat of the statutes and why it is that they're not being used more often right now, regardless of these kind of pieces that are being tweaked, that are being looked at being tweaked this morning. And so a more comprehensive approach to these reforms, I think, would make much more sense. Specifically with this bill, when you're removing the history of non-compliance as a criteria for appropriateness for an order of MOT, you're really then just going to be assuming that this person with no history of non-compliance with treatment or previous involuntary hospitalization will be non-compliant. And in the moment that person is in a situation where they're involuntarily hospitalized, but there are a number of situational or clinical issues that may cause somebody to be involuntarily hospitalized that have nothing to do with whether or not they're currently complying with their treatment. So they may be complying beautifully, and something goes sideways on them, and they end up being committed anyway. So again, I think even listening to the gentleman's testimony, hearing that there is confusion among his colleagues and some of the other special justices, it just bears repeating that a comprehensive look at this decades-old statute really is the appropriate course of action on this. Thank you.
Good morning, Madam Chairwoman and committee members. My name is Heather Zell. I'm with the University of Virginia, so I'm part of the group doing some of the work that my colleague from the Disability Law Center mentioned, and to what Ms. Faison just mentioned as well. I think it's sort of worth noting we are taking a comprehensive look as well in the coming year, and to speak to this bill particularly, which did not come out of the work group. We're sort of in a neutral position, neither for nor against, because we feel it needs further study. To understand, there's certainly, as some of the testimonies already noted, there's quite a range to be understood in what folks are experiencing and what works for them, and that's where there is this different criteria between going sort of directly to an MOT at a commitment hearing as opposed to after hospitalization. So we don't have an answer yet, but suggest deferring consideration of this for a year until we have a chance to look at the data, which we do believe we have and would be able to speak to with more detail, excuse me, where such criteria may be best placed or removed. Thank you.
Good morning. My name is Marco Rubin. I'm an Arlington County resident. Thank you for allowing me to address you. I'm speaking from the perspective, good to see you, speaking from the perspective of a parent of a 22-year-old who has been hospitalized 10 times in an acute state over a 2-year period in the situation. My input today is aligned with what David just said a moment ago. Entering into this situation as a user, first-time user, we had no idea what an MOT was. I couldn't tell you what an MOT was from a CAT before this whole process started. So in an acute situation like ours, but for the good grace of Arlington PD and half a dozen SWAT teams who came into our house, no injuries happened. However, as I think some of the people who've been users in this situation will find it, I don't intend to be critical of Arlington CSB or the medical community there, but I'm suggesting that there's a case study here in pardon me, I'm a little nervous. So in his first bout of psychosis, it became clear that no one told us how to build the airplane while we were flying it. We didn't know what an MOT was yet. The judge didn't tell us, the clinicians didn't tell us, no one told us. And we've gotten to know Sean through this process again. Sorry, a little jumped up. Fast forward, he's gone through an MOT program for the first time. We found out about an MOT the 6th time. After 10 hospitalization tests, the 6th time is the first time we heard about it. Blown away. This is Arlington County for crying out loud. Again, I did not intend to be critical. My takeaway from this is I don't pretend to be as informed as David and others who are clearly expert in the intricacies of the MOT process and its pluses and minuses. But my sense of it is, where did the information breakdown happen? And it seems to me that, with all due respect to our magistrates and judges and even CSB people in Arlington, there has to be just a massive education program to raise the level of awareness that's going on. So that's my story. Thank you.
Thank you. Thank you for your testimony. Okay, and are there any other questions from the committee?
Madam Chair?
Yes.
I'd like to make a motion, and I'm going to have a series of bills that deal with MOT as well too. And the sole reason I brought these bills is just as Marco just stated, is there's a lot of misunderstanding about the current statute, the way that it's laid out, and so therefore we have a tool that is best used in an outpatient setting. I agree with a lot of testimony that's already been said. It's better to put people in a less restrictive way. And so we created this work group that through the Deeds Commission that has taken a hard look, a comprehensive look at the mandatory outpatient treatment. This item has not come up from that, but that work group is still continuing to make recommendations. And so I would move that we continue House Bill 1026 and send this bill there so that we can understand what the repercussions are of making this change.
Madam Chair?
Yes, I'll give that. I don't
know that I object to that. I'm sorry, I speak because of the motion, I guess. Might we delay that vote until we see what we're doing with the other bills? You know, we have 4 or 5 bills in this space. If this ends up fitting neatly within it, I don't know that we need to delay a year. If it's somehow contradictory or not there, then unless you're gonna do the same thing with all your bills, in which case.
I think I can weigh in too. I was speaking prematurely from another bill, but we've actually had direction from our chair that would go along with Delegate Hope's motion.
Madam Chair, I mean, the only difference I would say is that the MOT bills that I brought have gone through that process.
I don't have any strong feeling. You know, 3 chairs, chair. Wanted to happen, it's gonna happen.
Okay, so we've had a motion. Is there a second?
Second.
It's been moved and properly seconded for us to continue House Bill number 1026 to 2021, and that is a voice vote. All of those in favor say aye. Aye. Any opposed? Okay.
Madam Chair?
Yes, go ahead.
Reconstituting the Deeds Commission membership, and if Delegate Adams would love to join us, we have several openings on the minority side.
We will send that message along.
He's interested.
Thank you for the invitation.
Delegate Corey, will take up House Bill 1321.
Good morning, Madam Chair.
Go for it.
Members of the committee. This bill is huge because there are some changes in sections of the code. So I am going to read a regular language summary first.
Okay, and I'm sorry, if you could just speak up just a little louder.
I said that the bill is very long because there are changes in different sentences scattered throughout the code. And I am going to read a summary in relatively normal English first to give you all an idea, because it's very dense to try to find the pieces that are changed in the code. This bill creates a supported decision-making act which allows an adult with an intellectual or developmental disability to enter into an agreement with another person called a supporter for the purposes of having the supporter assist the adult in making decisions to manage his or her affairs, giving adults who need assistance a less restrictive means of receiving such assistance. And it also amends the definition of guardianship to include this kind of arrangement. Essentially, this bill comes from a court decision in Norfolk several years ago, where a young woman with intellectual disabilities who was living at home wanted to marry her boyfriend, who also had intellectual disabilities, and her parents would not let her, even though she was over 21. So she took them to court. And what came out of this was the decision to allow her to marry him with a supported decision-making act agreement, as opposed to a guardianship or completely independent living. So this is a step in the middle, allowing people to be independent who might need assistance in making important decisions. And there would be a letter signed between the person, intellectually disabled person, and the supporter, and the court would have the letter. More?
I guess we can pause there. Are there any,
Oh, excuse me, Madam Chair, I just want to be sure, this came out of the Joint Healthcare Commission study, and the study was 2 years long, and the year before that, I was working on the concept, so I know I'm very familiar with it, and I'm concerned that I'm not explaining it very well. So I hope people will ask me questions.
So a supporter could help.
Oh, excuse me, I have a supporter to help too.
Let me first see, are there any questions thus far? Okay.
Yes, Madam Chair.
Okay. If you wanna come on and briefly see if there's anything that you can add to what's already been stated.
My name's Stephen Weiss, and I'm with the Joint Commission on Healthcare. I'm a staff person, and I did the study and presentation on supported decision-making, which is also posted online on our website. I think that if you have any questions that might be more helpful, the supported decision-making agreement is something I think mostly targeted for IDD youth coming out of high school, so that the parents and the family members, caretakers, have another option besides guardianship that they could review and look at to see if it's something that they would want to do. The reality is that a lot of people are told in different areas, especially in school, that they need to get a guardianship for their IDD child, and when the parents do that, they don't realize exactly all of the rights that that person loses once they go under a guardianship. And so this is a way to preserve a person's rights, decision-making rights especially, and also give them the ability to sign an agreement, a formal agreement that they can use when they have to make decisions on where to rent an apartment, what kind of medical care they might have. This could be used with powers of attorney, or it could be used without, depending on the capacity of the person. And this is a situation where we felt like parents and their caretakers would know best whether or not a person has the capacity and can communicate their decisions and their wishes and desires when they have to make a decision on something.
Delegate Willett.
Madam Chair, question for the speaker.
Sure.
So I'm just curious how many other states have adopted similar support programs like this? Is it pretty common?
Jonathan Martinez from Syracuse University, who's been spearheading this across the country, is here to speak to this, and I believe that there's 11 states, and it's kind of a growing movement because it is a least restrictive process. Thank you.
I'm happy to speak. I was going to ask to after Mr.
Yeah,
Weinstein.
did you have an answer specific
Yes,
to
the answer is 11,
Okay, thank
with
you.
pending bills in other states.
Any other questions from the committee? Do you want to hear testimony first?
Whatever that, we have 4 pages of italics to walk through. I don't know.
I believe, Madam Chair, there are a few other people who would like to speak to the bill.
Sure, okay, if there's anyone here to speak in favor of House Bill 1321?
Thank you, Madam Chair. Melissa Charns-Gibson with the Disability Law Center of Virginia. The Disability Law Center did provide comment on the JCH study. We believe that supported decision-making, or SDM, is an idea whose time has come. We've supported and followed it with great interest because of the value that it has for people with disabilities. So we support legislative efforts that improve protections for individuals who are subject to guardianship, that enhance understandings of other types of arrangements and allow for the statutory recognition of supported decision-making. Supported decision-making posits that decisions made in consultation with supporters are valid. And an important part of supported decision-making, sort of an animating principle, is that you're encouraging people to use the capacity that they have, meeting them where they are, and encouraging them to develop and maintain decision-making skills to the greatest extent that they're capable. And we think that the value of SDM agreements is that they really evidence to others that there's a plan in place for making decisions safely. And so a statutory scheme that allows for that can be very beneficial.
Okay, thank you.
Good morning, Madam Chair and the committee. My name is Jonathan Martinez. I am with the Syracuse University Burton Blind Institute. I'm also the project director of the National Resource Center for Supported Decision-Making. That is a federally funded entity, although I'm not here using federal funds. I'm here as a Virginian, albeit transplanted. The modern supported decision-making movement began in 2013 in Newport News, Virginia, with a young woman named Jenny Hatch that I had the honor to represent. Ms. Hatch was the first person to defeat a motion for guardianship at trial because she said she used supported decision-making. Supported decision-making is just what you're doing right now. It's just getting information from people who know so that you can understand things and you can make decisions for yourself. My colleague just gave great reasons why you should pass this bill. I want to tell you why you shouldn't fear it, because Delegate Corey, you may have received comments, others may have received comments on how this bill could be dangerous and lead to problems or abuse or bad decisions. And I'm here to tell you that we've got almost 7 years of data since Texas passed the first supported decision-making bill in the wake of Jenny's case in 2014. Since that time, 11 states have passed similar bills. And as an aside, ma'am, I'm going to tell you I've been involved in many of those bills, and this as written, and especially if you adopt some of the changes recommended by the ARC of Northern Virginia, is the finest that I've seen. We have not seen those troubles emerge. Not in Texas, not in Rhode Island, not in Delaware, not in Indiana, Missouri, Alaska, Nevada, or any of the other states that have passed similar bills. What we have seen is an emerging body of research that says that when people use supported decision-making, their lives get better. And that is because we have 40 years of research that say when people with disabilities have more control over their lives, when they have more self-determination, they have demonstrably better lives. 40 years of studies say that people with more self-determination are more likely to work, more likely to live independently, more likely to be healthier, and yes, safer. And the research that we are conducting now is indicating that using supported decision-making to make your own decisions, instead of having someone make decisions for you, leads to increased self-determination. One last comment. You may hear that this bill is dangerous because it will end guardianship. It will not. Guardianship will always be an option for people who truly need it. But what this bill does, as Mr. Weiss pointed out, is it gives people another option. And in particular, ma'am, what I love about this bill is that it puts an obligation on schools to help people learn to make decisions, because statistics show that schools are the #1 resource for guardianship. So if we have people from a young age making decisions and knowing this is an option, then the only people going into guardianship will be the ones who truly need it. And that's why you should pass this bill. Thank you so much for your time.
Thank you. Anyone else? There.
I speak to a couple of other changes in here that the members might be.
So as we have this bill in front of us, we do not have any amendments. Are you putting forward amendments?
I do have amendments, and, excuse me, just got them on Sunday night from DARS, and I don't know, do you have any?
It'd be Sarah.
No?
I don't have
No,
any.
sorry, Sarah. Kristen at DLS. Okay. I did,
Were they emailed
Are they line
to her?
amendments?
yeah, they are line amendments, and I can,
Did you email them last night?
they emailed me, DARS emailed me last night at 10 o'clock.
Do you have a copy of the line amendments with you?
Yes, I do. Well, while you're doing that, thank you, thank you.
Monday and Wednesday.
Because it hasn't been attached. Yes, Dudley Court.
It's my understanding that the changes are technical changes, putting a word in another section, moving a sentence over here. We've had, the AG and DARS working on trying to agree what language goes in what section. For example, the guardianship definition was something that, they worked on for quite a while before they came to agreement. The only part of this bill that refers to school systems is a section that says when a student who has an IEP is graduating and leaving the school system, it's important for the school system personnel to be sure that the parents understand or the guardians understand the IEP and that the student understands it also.
Okay. And is there anyone here to speak in opposition to, House Bill 1321?
Hi, my name is Steve Burns. I'm an elder law attorney here in Richmond. I am also the volunteer board member of the Virginia Academy of Elder Law Attorneys and chair of the Public Policy Committee. I'm also a former special mixed basketball coach, and baseball coach, and I'm a parent of a daughter with Down syndrome. So I tell you all that to let you know that I come from a place of the law and also a place of authenticity. So our overall concern is that supportive decision-making exists in this gray area in between guardianship and power of attorney, which can be problematic as presented as an alternative to guardianship, when truly it requires an individual to understand the nature and consequences of the agreement that they're signing, which is the same that we're doing for power of attorney. So when I meet with my parents, when I meet with my clients, a large portion of my client base are parents with children with various disabilities, whether it's 18-year-old with Down syndrome or 50-year-old mental illness. our conversation really surrounds, one, does your child understand, could they enter into a power of attorney agreement? Do they understand the nature of the agreement, the consequences of what they're signing? If the answer is yes, then we talk about, okay, does that power of attorney provide them enough protection, provide your child enough protection from exploitation, from outside influences? So we're supported decision-making agreements, so we're not opposed to the idea, the concept of it, but we believe it goes hand in hand with a power of attorney arrangement, something along those lines. It's only when we've gotten over that hurdle of we don't understand the document, we don't think it's going to provide enough protection to somebody, then we go down the guardianship road. So the bill is written marries guardianship and support decision making. It requires a guardian ad litem in a guardianship process to opine whether or not this agreement is appropriate or would be a suitable alternative. When our position is really, it's not an alternative. We've already gone down this path. So the law already says the least restrictive means a power of attorney. If that's appropriate, that's what we should be doing. So our concern is the way the law is written, it marries the two. We do think it would require, we do support the concept of it, but we would like to see some additional study, some additional input from maybe Boyd Graves or the VBA, something like that. That's all I have. I'll take any questions if there are any from the committee members.
Thank you. Is there anyone else here to speak in opposition? Okay, Delegate Hope.
Thank you, Madam Chair. I have a question for you, sir. This has been a study on the Joint Commission on Healthcare for a couple of years. Were you all consulted? Did you provide comment or feedback?
Not that I'm aware. No one from our organization was contacted. And we are familiar with very familiar with the Jenny Hatch case. I would, I don't want to go into the details of that particular matter, but I'm not aware that anyone from our organization or the VBA was had input on this. But maybe Mr. Weiss can answer that question.
So as I presented in the Joint Commission meeting, I consulted with a handful of attorneys, 2 judges, a guardian ad litem, and I went up to Fairfax and sat through an entire guardianship process with the court clerk up there. I did talk to somebody with the VBA on their Wills and Trusts Committee, and they didn't seem to have any issues with what we were working on or the study or what the conclusions were.
Madam Chair, may I?
Delegate Quinn.
This study, as all the studies that the Joint Healthcare Commission works on, this one included a stakeholders group that met off and on for a little more than 2 years, and ARC of Virginia was part of it. I'm sorry I don't have the list, but it was a very, very long list of organizations that deal with people who would need supported decision making. I want to emphasize one thing that seems to have been overlooked with all the comments, and that is that supported decision making is not like power of attorney. Power of attorney, you do not have the rights that you have in supported decision making. We always talk about how we want people with intellectual disabilities to go out into the community and be supported by community services, have an active life, develop a career, et cetera, et cetera. If they have to give power of attorney to someone, that's not going to happen. This arrangement, codifying this arrangement, which frankly exists a lot anyway, especially in families, will help people with intellectual disabilities be able to live more independently than they do now.
Madam Chair, can we move the technical amendments? Where are they?
Let's hear them first before we have a motion.
Madam Chair.
Based on this, I'm not sure I'd necessarily call these technical.
Okay.
Okay, so working from what I have here, I have not had a chance to really look at these, but it looks like, from what I have here, what we would do is on page 2, with the definition of supported decision-making agreement, that definition would be changed to include a list of 5 specific things.
I'm sorry. This, usually when we have line amendments, it's like one sheet, it's inserting a word. This is inserting entire So this would require a substitute in order for us to give council time, give us time to digest it, cause I think, we are just now getting this one, fully digested.
I apologize, like I said, it came to me last night at 10 o'clock last night, so, I understand the confusion.
Madam
Okay.
Chair,
Delegate.
I understand this was looked at by the Joint Commission on Healthcare. Was this draft voted on and approved by the Joint Commission? And I guess just as importantly, was the amendments that were dropped a couple minutes ago also approved by?
Yes.
They voted and said this is the
Yes,
words that you've
yes,
just given,
it-
Ms. Stanton.
This was supported, to
The-
be legislation to go forward.
So,
And
I'm sorry,
with-
Paul,
and
I
the-
wanna
oh,
re-ask
okay,
this
I'm
question,
sorry.
Delegate Corey, the email that you just said that you received last night is part of his question as to whether or not the Joint Healthcare Commission vetted the language.
I
Is your
understand.
answer yes to that?
I understand. Well, I'm sure you know that the Joint Healthcare Commission is not meeting at the moment. However, the original bill was supported by the Joint Healthcare Commission and directed to be legislation. Senator Donovan is carrying one in the Senate. What I got last night came from working together with DARS and the Joint Healthcare Commission director and researchers who were working to clarify and remove some concerns that DARS had. So, yes, it is.
So I want to restate what I am hearing to make sure that the committee is all on the same page. That the concept was discussed and researched with the Joint Commission on Health, but that the members of that, the legislative members of that have not seen the draft or amendments as we have before us.
The members have not, Madam Chair, the members have not seen the changes that DARS is making. The staff has assured me that the bill is the same, it just fits better into the code with these changes.
Delegate Bell.
Madam Chair, I'm ventilating over here because we at some point have to start looking at the words and whether the words do anything like what she's describing. I like the idea of it. She has said at length that many of these things are already being done. If something's already being done, it is a grave danger to put stuff in the code because you leave stuff in and put stuff out, and that's a big deal. There's language in here which is precatory about all adults are presumed. I have no idea what effect that would have elsewhere in the code. But in any case, if the intention is to move forward with this, 9:30 on a Monday, I would respectfully request let staff start going line by line and tell us what it means, because I don't, I've heard ideas, I've yet to hear, the existing code is X, this is Y, and we're talking about what we want to do. I mean, giving people friendly advice, you don't need code for that. In fact, putting it in code is limiting and dangerous. If you're giving the supported decision maker power, the supporter power, then that has significant legal impacts, which might be great. But I'm not sure I see how it fits in between the POA. So power of attorney can be withdrawn at any time. Person has capacity. You don't like where the POA is going, you pull it. Guardian can't. Those are our two boxes. And our third box is friendly supporter that helps you make decisions. I mean, I like everything she's saying as ideas. I'm not sure that that's what the.
Madam Chair, is there a way, I also very much like the concept, I understand the concern about language at the last minute, and I also understand this is supposed to be the last meeting. Is there any way we could take, I probably have to have another meeting, but take it by and do the other bills and maybe come back in a couple days, have a special meeting on this bill after everyone's had a chance to examine the language? You'd have to probably schedule another meeting, I don't know.
I am not inclined to schedule another meeting for one bill, especially when we've already taken this by for a week, in order for us to get this before us this now.
And Madam Chair, I do apologize that the group is larger of input, it's just larger group than I've been able to control. But if you would consider putting it by, continuing it, I would appreciate it. And that way, at least when I have a final that I've seen the language of, and the rest of the committee could see the language of, people would be able to make a decision.
I'm sure I would be willing to.
Till next year.
And
Rule 22. Yeah, I make a motion to
So it's been moved and properly seconded for House Bill 1321 to be continued to 2021 with work in the interim, so that everyone can see the draft prior to our subcommittee meeting. Sorry, I was editorializing in that motion. The motion was to continue, was seconded. Clerk will open the rolls and members shall vote on. I'm sorry. All those in favor say aye.
Aye.
Any opposed? Okay.
Can I say something, because I think it
Yes,
sounds like a
Delegate.
lot of the advocates from the room. We're right, we say sometimes, we don't pass ideas, we pass laws, and the issue would be if it's already something that
Right.
I think most people know, I have a son who's now 17, he's right in the wheelhouse of this, it's a great idea, but, if we already can do it, it shouldn't be put into the code, because when you put in A, B, C, and D, and you leave out E, all of a sudden literally, you can't do E, whereas right now you can do A through Z, so it's very important, if we can already do it, leave it alone. And then where it has legal significance, then all of a sudden you have to be very precise about how it fits into the guardianship, power of attorney, just a good friend, that's all.
No, Madam Chair, may I make a final statement?
Sure, very, very briefly.
Very briefly, and thank Delegate Bell. I understand your concerns. It's important, however, that the decisions that are made with a supporter are able to stand up in court, and that is the main impetus for adding this into the code. Okay?
Thank you.
Thank you.
Madam Chair, very briefly, I promise, very
Like,
briefly.
2 seconds briefly.
I think
It has
that
been
guardianship is rife with abuse in Virginia. I think this concept is a really good one to have an intermediate step, and I look forward to having you work out all the language and making it right.
Thank you.
Thank you.
Thank you, members of the committee. I know this was longer than you expected.
Delegate Davis, House Bill 1127.
Yes, ma'am.
All right, go for it.
Again, we have a substitute coming around.
And it's the something that we talked about, right? The most recent.
Sure. Yes, ma'am, yes.
There's a lot of last minute.
Yes, ma'am. And I got one, I have a last minute change with that as well once it arrives, but it's a very small line change, or a word change.
Thank you.
There will be, I guess, we need, I guess, to adopt this before we can make the word change together.
Okay, it's been moved and properly seconded for the substitute. All those in favor say aye. Any opposed? Okay, the substitute is properly before us. Do
Thank
you have
you.
a line amendment?
Madam Chair, if I could just, please, ask that an amendment be, moved that changes on line 21, July to October.
So moved. Or I make that motion, I should say.
Is there a second? It's been moved and properly seconded for a line amendment to change on line 21 from July to October. All those in favor say aye.
Aye.
Any opposed?
Thank you, Madam Chair. So right now, there's a redesign of Medicaid-funded behavioral health services, and the full implementation of the new design of the school-based behavioral health services that will replace present existing therapeutic day treatment, or TDTs, are at least 2 to 3 years away. There's significant concern that Medicaid MCOs are already adjusting the manner in which the TDTs are being authorized and reimbursed, and it's resulting in an increase of authorization denials for TDT, and in cases where it is authorized, the number of units approved is not sufficient to meet the needs of children and adolescents, and it's also creating unsustainable reimbursement structures for the providers as well. So this legislation just directs DMAS to gather and report on specific data to determine changes to the nature in which TDT is being authorized, since the Medicaid MCOs assume full risk of their contracts on July 1st, 2019, and then report on those changes, and also to develop an implemented transition plan to direct the MCOs in authorizing TDT in a way that minimizes the gap in coverage until the school-based behavioral health services are fully developed and implemented at phase 3.
Okay, thank you. Are there any questions from the committee?
Can I ask a very simple question?
Delegate Levine.
What is therapeutic day treatment?
So I can give you a baseline, but there's someone here I can give you the 30,000 foot view, but I can't do it justice. So Mindy, if you like to.
Absolutely, thanks, Madam Chairman. Mindy Carlin, I represent the Virginia Association of Community-Based Providers and Association of Community-Based Providers across the state. So therapeutic day treatment is a Medicaid-funded service that's currently being provided to kids in the schools. And if you'd like some more detail about that, I have some members that actually do that. But it is the only school-based Medicaid-funded behavioral health service that exists and is a choice for those kids today.
Madam Chair?
Delegate Levine.
Can I get a little more information? So what does it entail? What are you doing?
Absolutely.
Who are you helping? What are you telling me? Sorry,
Using
I'm sorry for my ignorance.
I'm
I don't,
using a
I don't know the
lifeline.
term.
Sure. Hello, committee and Madam Chair. Thank you so much. Stephen Stark with National Counseling Group. Therapeutic day treatment is a mental health and behavioral health service provided to children around Virginia, funded by Medicaid, created by the Department of Behavioral Health and Developmental and Disability Services. It's a service that is provided within the schools to children who are at risk of serious decompensation and other behavioral issues, so as to put them at risk for hospitalization at times. It's a service that not only addresses their needs within school throughout the school day and throughout the week, but also wraparound services to include home-based services, family-oriented services.
Madam Chair.
Yes, Delegate Bell.
When it's too much for the school counselor to manage, that's where the winnowing, if these are the kids who need significantly more care than that. This year, there's been a significant decrease in approvals through DMAS, with no change in any of the statutes or regs, but suddenly a lot of kids who are getting them year by year are not getting them anymore. I don't know if that's what's prompting the delegate's bill, but that's the issue. All of a sudden it's happening.
And so, I'm sure,
Delegate.
if I might with this, so the impetus on this is that because you've got a bunch of folks that are moving into the MCO model, the MCOs are making decisions, and what we're doing with this is saying, you don't get to make this call. And that's really all we're doing, so.
Madam Chair, that's exactly it. I actually ran across this in the fall of last year. I knocked on the door of a lady that provided these services, and she made me aware of the students that she had been helping. Because of this transition, the TDTs were not being approved, or the hours had gone down dramatically, and it was impacting the ability for them to truly provide those services to the students in this transitionary phase.
Okay, and Delegate Davis, do you have a budget amendment that goes along with this?
No, with this amendment, no ma'am. I don't think we need it. I don't think we have a fiscal impact on this one requiring a budget amendment.
On a substitute, there's not, on the underlying bill there was.
Yeah, I think it should be more than enough, I think, to cover the substitute, but we haven't seen the fiscal impact on the substitute yet.
Any other questions from the committee? All those here to speak in favor of House Bill 1127, the substitute, please come forward.
Thank you, Madam Chairman. Mindy Carlin, again, with the Virginia Association of Community-Based Providers. We are appreciative of Delegate Davis's willingness to include these amendments that not only will help ensure that kids aren't falling through the cracks at this transitional time, but that we can also gather data that can help us determine kind of what's happening to those kids since the change over to managed care for behavioral health, and think that can also inform how school-based services are redesigned as well, which we are grateful for the chance to work with DMAS on. So, thank you, Madam Chair.
Good morning, Madam Chair, to committee members. My name is John Saley. I'm an LCSW. I'm on the board of the VA-CBP. I'm also the chair of the Board of Social Work, but I'm not here to speak for the Board of Social Work. I do like wearing the pin though. And I've been working with therapeutic day treatment services for many years, and what the delegates have said earlier is right on the money. It's like what's happening to the when the services are denied. We have large service providers that are actually pulling out of providing the service because of the reimbursement rates gone astray. So we're able to study it and look at it and to be able to report back on what other things are happening to them. Are they going to the hospital? Are they going to DJJ? These are kids that most of them are in outpatient therapy concurrently. So the answer can't be, well, they went to outpatient therapy because that's not enough service for them. So, any questions for me?
Thank you.
Again, Madam Chair, we're Stephen Stark with National Counseling Group. We support this entirely. Given the concerns that have been raised not only by public and private providers, but also the consumer families within Virginia regarding the vacuum of these services in today's zeitgeist, we just want to ensure that data is provided as opposed to conjecture, and that a plan is in place to ensure that people's needs are met while this transformation is taking place.
Thank you.
Thank you.
Anyone, oh, sorry, didn't see you.
Almost got stepped on. Madam Chair, Jennifer Fedora with the Virginia Network of Private Providers. We support this bill, particularly with the data that's now included in it. We think that will inform discussions that we have sort of requested in a budget amendment, so it'll all fit together very nicely in reason. Thank you.
Thank you. Anyone here to speak in opposition to House Bill 1127, the substitute? Okay. Delegate Davis, any last words?
I couldn't say anything better than the people behind me, so it's going to be a pleasure of this body to move it forward so we can track and make sure we're not letting anyone fall through the cracks during this transition phase.
Madam Chair?
Yes.
In line 16, should 2010 be 2019?
Yes, you should.
Okay.
Thank you very much.
I move to amend 2010.
You're a lawyer, so.
To change it to 2019.
It's been moved and properly seconded for a line amendment on line 16 to change to 2019. All those in favor say aye?
Aye.
Okay, so that change has been incorporated, and it'll all be in the So if there is such a motion, the motion would still be to recommend to report and refer to appropriation.
Madam Chair, just as a question on this, other things given in my head, I understand what we're doing and I appreciate this. My only question is, in the reduction of services that are there, I can just if for some nods, I don't need anybody to testify on this. Have we seen a reduction in outcomes as a result of this?
Yeah.
I mean, so, okay, because the argument's gonna be pushed back from the MCOs that what we're doing is saying, you have to manage the care, but we're gonna tell you how to manage the care. And I understand both arguments, and there are times when it's appropriate for us to do that, and this might be one of those, and so.
Madam Chair, one last, hopefully, question, just so I understand what we're doing, and I think I do. But the heart of this is it's during the transition to the full implementation of the redesigned school-based services to minimize gaps. Could someone please, either Delegate Davis or someone on this committee, explain to me what is transitioning? What is changing, so I understand what we're actually doing here?
So, Delegate, there's a redesign of the whole behavioral health service, I guess, network scenario, but they're going to replace the therapeutic day treatment with I guess more of the Medicaid MCO type scenarios. But this transition is about 3 years away, and so it's kind of being lost in the, I guess, in the transition phase. So you have people that are not getting, students, they're not getting their TDTs approved, and then much smaller allocations when they are. And that is, our students are starting to fall through the cracks.
And Delegate Davis, do you want to?
Again, yes.
Yeah.
I'm sorry, I didn't bring one of those pop, but Minnie can actually, yeah.
Thanks, Madam Chairman. So the redesign, DMAS is undertaking a complete redesign of all of the services along the continuum of care that are being provided that are community-based. So everything from intensive in-home to outpatient to TDT to the full range. Right now, there are budget amendments with language and investment for that first phase of redesign, which includes a number of services. It does not include school-based services, so that will come at a later phase, and you will hear about that.
I now understand the bill.
Thank you.
And I move to report and refer it.
Okay, so I've heard a motion to report as the substitute and refer to appropriations.
As amended.
So all of the amendments that we have approved today will be included in the new substitute. So, yeah, it'll go through as a substitute. Is there a second? Okay, so it's been moved and properly seconded. Clerk will open the rolls and members will record their votes. And clerk will close the roll, and that recommendation passes 6-0.
Thank you, Madam Chair.
Delegate Davis. Okay, so let's pick up with Delegate Hope. Delegate Hope, which would be your next bill number?
Let's see, why don't we start with 699 and go in numerical order.
Okay.
If that works. I asked Heather from the University of Virginia to come up on these series of bills that we're presenting. This is distinguished from the bills that you heard from Delegate Adams. I first brought similar bills of this type of reforming our mandatory outpatient treatment process
2 years ago, and then it was asked to be continued to do a study. So we've been studying through UVA and through the Deeds Commission, a large stakeholder group that has met multiple times to take a look at reforms to our mandatory outpatient treatment setting. And so these are what the recommendations that have come out of University of Virginia and has gone through the Deeds Commission. The first one that we have, House Bill 699, and I know Heather can fill in some of the details. There you are. They can fill in some of the details, but essentially what we do is we are clarifying that mandatory outpatient treatment order remains in force until the court rescinds it or it expires, even if the person revokes their agreement. Some people believe that, and I say some people, I mean CSBs and judges might believe that when someone, oh, we do have an amendment, I'm sorry. Yeah, I do have an amendment. Sarah, you just need to blurt it out.
No, man, it's confidentiality.
All right, well, I waive confidentiality
There we
for
go.
all my bills. I have no secrets.
From now into the future forever, that's what I heard.
I think I have enough copies for it. So you get one.
And by the way, each of you should have received a copy, sort of a summary of all of these bills that came from UVA explaining what each of these bills do. And
Delegate, can we report the amendments,
Yes.
please?
The amendments there are 4 line amendments. The first amendment, line 99, after examiner, insert who shall meet the requirements set forth in section 37.2-815 and we're going to include that again on line 117, so that makes clear that the examiner meets the requirements that we've already established in that section for these types of examiners. The third amendment on line 144 adds a comma after the word order, or strikes the comma after the word order, and inserts the word or, and then adds after the word physician, comma, or other responsible, strike, comma, or other responsible person, so. Yeah. So we're taking the other responsible person out of that line.
So I have a motion on the amendment.
So moved. Second.
It's been moved and properly seconded for the amendments as reported. All those in favor say aye.
Aye.
Any opposed? So the House Bill 699 as amended is in front of us.
Okay, so thank you, Madam Chair. And so as I said, this clarifies that the MOT order remains in force until the court rescinds it or it expires, even if the person revokes their agreement. The second thing that it does, it clarifies the scope of the examination that can be ordered by the court when a petition for review of a MOT is filed. When a CSB petitions the court for review of an MOT order for a person's material noncompliance with that order, an examination of the person can be ordered by the court. There's been confusion over whether that examination is just limited to determine whether the individual meets the criteria for the involuntary commitment to a hospital. The proposed amendment makes it clear that if the original MOT order is a step-down order, and remember Sarah educated us on the difference between the orders, the purpose of the examination is to determine whether the person continues to meet the criteria for the step-down. And finally, the next thing that 699 does, it provides that the criteria used for the court to decide whether to continue to alter, rescind, or extend the MOT order are the same as those used by the court to enter the original order. Currently, the language and statutes regarding enforcement of MOT, rescission, or extension are not clear in setting out that the criteria apply in each of those situations. The proposed amendments make it clear that the criteria that the court should apply are the same criteria that are used in entering into the MOT order. And so those are the 3 aspects that we're trying to address in House Bill 699. Heather was one of the leaders in the work group in pulling all this together, and she can answer any technical questions that you have or something that I might have missed.
And Delegate Hope, you said this was from the Deeds Commission?
That's correct. There's a separate work group that was overseen by Heather's group, Professor Richard Bonney at University of Virginia, and we've met multiple times in that smaller work group, and we made our recommendations to the Deeds Commission. All these bills are Deeds Commission, and this was the recommendation from the commission. So all 4 of these bills went through that process. Madam Chair.
Delegate Bell?
You just said it, I just wanna make sure we get, as you know, we have a lot of concepts and groups and work groups. This was the ones that the Deeds Commission endorsed.
That's correct. All the 4 bills that, yes, that's the process.
We did have drafts that day too. Any questions from the committee? Okay. that came to speak in favor of House Bill 699 will come forward.
Did we want, I know our comments actually address all four of the bills, so we could
Yeah,
wait
come
till
on.
after.
Yeah. Because we're going to vote on them individually, so
Okay.
you might not have to repeat yourself.
Okay, I'm Lisa Daly, I'm Director of Advocacy for Treatment Advocacy Center, and I was a member of this work group. As part of this process, we looked at relevant research coming from both the APA and SAMHSA. We conducted surveys with a number of the special justices, and we had members of the work group that were practitioners either at CSBs or were otherwise involved as care providers. And we considered a number of options. We did actually take a vote, and we were in unanimous agreement upon this as in addition to all of the other recommendations that had gone through the subcommittee. And we endorse this as a effectuation of the work group's intent.
Okay, thank you. Next.
Thank you for the opportunity to offer testimony in support of House Bill 699, 700, 702, and 713 about Virginia's mandatory outpatient treatment law. My name is Sean McBride. I'm a student at George Mason University. I was diagnosed with schizophrenia in 2017. These laws have applied to me in the past, so I am familiar with what works about them and what does not. I am also in a unique position to have experienced the consequences of what happens when they fail. In my written testimony, I described the development of my illness and the various things that went wrong with Virginia's treatment system. Today, we'll talk specifically about my experience with MOT and why I'm asking you to pass these bills. I was involuntarily hospitalized in early 2017 during a psychotic episode. This was my opportunity for me to be stabilized on medication and offered the support that I needed to emerge from my psychosis. Instead, I was discharged while still totally out of touch with reality in an unfamiliar county to a homeless shelter. I wasn't under supervision of any kind with either the court or the CSB. Nobody but my mother was paying attention to my condition after I was discharged, even though I was coming from the highest level of care. I did not qualify for MOT because the way the law is currently written, I would never have agreed to an order. I didn't believe I needed any treatment. Even if I had been eligible for MOT, 90 days would not have been long enough to break through my psychosis. It took nearly that long in inpatient treatment before my medication took effect, and I could think rationally again. I was lucky that my mother was able to obtain guardianship, which is not easy. Specifically, she had to seek help from lawyers, politicians, and spend a lot of money, resources most people don't have access to. She used guardianship laws to intervene because without intervention I would still be homeless, suffering from psychosis. I wasn't being stubborn and I wasn't waiting to hit rock bottom. I was not in touch with reality. I would like to emphasize, I would not eventually have sought treatment. My mental state skewed what I perceived to be in my best interest away from what was actually in my best interest. People who are experiencing psychosis should be given the opportunity to reconnect with reality so the choices they make are truly choices. I'm grateful that intervention gave me my life back in 2018, but I lost more than a year when it failed in 2017. I never want that to happen again to me or anyone else. If I'm ever again in a situation where I lack the capacity to understand that I need treatment, I will rely on these laws to intervene and help me get back on a path of mental health. I'm asking you to fix the MOT law so that it actually works as intended for people who, like me, may at some point in time require intervention due to the symptoms of my illness. Thank you.
Thank you.
Thank you for your time here. My name is David Fitzgerald. Sean, thanks so much for your testimony. It's just super powerful. I'm a father of a young man who's been managing schizophrenia, much like Sean has been for 10 years. And I want to talk about all four of the bills just at once. I support each of the bills that Delegate Hope has proposed here. I am a member of the CSB up in Arlington. For the last number of years, I've been able to see how the statute around involuntary commitment and mandatory outpatient treatment have not worked as intended due to their complexity. And here we've heard testimony about people asking for a rewrite of the statute, and I think that's a fine idea, and I think it'll come at the appropriate time. But in the interim, we have a chance to improve the statute and to make this clinically appropriate tool more useful to more Virginians. So we're not talking about a few people here. We're talking about thousands of Virginians every year who come under ECOs and TDOs because they are in crisis. They're suffering a mental health crisis. And what we want is we want to have least restrictive care for them as appropriate. And we don't want the statute being a tripwire for special justices or clinicians who don't think it's easy to administer, who don't think it's clear, or any of these things. So the 4 bills that Patrick has proposed here and that the work group has worked on, I'm a member of the work group as well, all tighten up the statute and make it more applicable. I want you to think about the cohort we're addressing. These are the people on continuum of care, like Sean was, and like my son was, who are in the most severe crisis on their path through care and treatment. And it's at that moment of severe crisis that these changes will help more people in Virginia. So I'm very supportive of it, and I appreciate your time.
Thank you. Is there anyone here, excuse me, to speak in opposition to House Bill 699 as amended?
Madam Chair, Colleen Miller from the Disability Law Center. As we said earlier, I join with Sean's comment that this is a system that needs to be repaired. I'm concerned that these tinkering at the edges kind of things will only add to the confusion about the system. And what is needed is a complete revisiting of how mandatory outpatient treatment, how forced treatment is handled. 699 may do the least amount of damage to the system, but I do think that these little bit of changes that happen along the way are going to add to the confusion that the courts have and the practitioners have about this, and would really encourage this committee to support a complete overhaul, or at least a complete revisiting of the system. Thank you.
Hi, Madam Chair and committee members. Again, my name is Jennifer Spangler. I'm a person that could be directly impacted by this legislation. I would like to address the Fees Commission and just let you all know that people who are impacted by services are not included in the work group, so our voice is not being heard with these bills that are coming forward. I would like to say that I oppose forced treatment because I believe it lengthens recovery, requires additional services, and increases the financial burden to individuals and the behavioral health system. The system is fraught with challenges, and what really needs to happen is for investment to be made into community supports. Psychosis, you're not going to be released from a hospital unless you are deemed to be safe, basically. So further adding to that, it doesn't make sense to me, honestly. I've had psychosis, been hospitalized several times, and the best thing for me is to get stabilized and then to go to my medical home and continue treatment that way. So we really need to be encouraging folks to, just like any other illness, you get out of the hospital for a heart attack, you start doing the things you're supposed to do, and you're on your way to recovery, and you're not requiring these expensive and I feel unnecessary services. Thank you.
Madam Chair, members of the committee, Jennifer Faison with the Virginia Association of Community Services Boards. I just want to clarify that the association does not oppose MOT writ large. And you all heard my comments earlier regarding the need to revisit these statutes. There's just one thing in particular with 699 that I will point out is that, as Delegate Hope mentioned, one of the provisions of this bill would nullify if an individual says that they will no longer comply with the consent to the MOT, that does not then count as a rescission of the order. And the reason that I point that little piece out is because depending on the policy decision that you all decide to make on House Bill 700, you would be putting the code in a position where if somebody says they won't consent, then it could then that would be, then mandatory outpatient treatment could not be ordered. But if you pass 699, then it would be in a posture where if somebody revoked their consent, it wouldn't count as a rescission of the order. So those two parts would be in a separate posture. And all I'm saying in that is, this is the exact conversation that I think, we're trying to have here, is that if you play with one little piece of this, and that's the consent piece, in this particular instance, you're going to change another part of the code, or if you don't do the same thing in both places, then you set up a further conflict. And so, again, I think you would need to consider a policy decision on House Bill 700, which the VACSP also opposes to.
Elizabeth Bolton-Clapton with Wilco. Good morning. I am opposed to one of the provisions of this. It says that you may not file a petition to rescind the order more than once in a 90-day period. If I'm in mandatory outpatient treatment and I'm taking a medication that is ordered for me, but I have physical reactions to it, and I only have the opportunity to do this once in a 90-day period, I have no provision to allow for those physical findings. I'm a case in point. Some of the medications that are prescribed exacerbate diabetes. They can make blood sugar go up, people gain weight. That's further contributing to their decompensation and not being able to effectively manage their own health care. So I oppose this bill for that and other reasons.
Thank you again, Madam Chairperson and committee members. I'd like to underscore a point Sean made, which is consistent with our experience. The Virginia Hospital Center kept their son in the hospital for 2-week periods, essentially coinciding with the duration of the insurance coverage. And it was, I don't know about the clinical threshold, but it was abundantly clear he was not well when he was released. This 10th time, he was in for an extended 30-day duration, and that got him out of psychosis. I'm not saying you can generalize from this case, but I am suggesting that the duration that's being offered to exit people is inconsistent. There is an uneven sort of clinical standard being applied, certainly at Virginia Hospital Center. And when we went to the adjacent county, they were shocked, absolutely shocked at what was happening. My point being that as a parent of a young man who's gone through psychosis, and now on the 10th MOT that was long duration, he's bounced out. It's exactly what Sean just said. Thank you for your time.
Thank you. Are there any further questions from the committee? Committee operates on motion.
Report.
As amended. I'm sorry, move to report and refer the amended bill.
May I second?
Okay, it's been recommended to report and refer with the amendments. Clerk will open the rolls and members will vote. Clerk will close the rolls and that passes 6-0. Delegate.
Thank you, Madam Chair. With House Bill 700, again, this went through the same exact process. All these recommendations are being made collectively. We have taken a comprehensive look at the entire code, and this is part of the interim report. House Bill 700, which you have before you, removes the existing requirement that a person agree to the proposed outpatient treatment plan before the person can be discharged from the hospital. Do I have an amendment? Okay, good. And so before the person can be released from the hospital under a step-down MOT order, this requires the agreement for a step-down MOT is incompatible with the goals of the statute and clinically counterproductive. The clinical grounding of both types of step-down of the MOT order. This was never the intent of the General Assembly, is to require this. That's why that's the M in the mandatory part of it. the court's finding that the person needs continued mandatory outpatient treatment after discharge from the hospital to end the person's established cycle of crisis and involuntary hospitalization. Sean spoke very eloquently about the need for MOT and making sure that a person who's in need of this support gets it. So the person's agreement to the treatment plan in this case of a step-down MOT order should not be required, and that's what the bill does.
Okay, and Delegate Hope, we heard previous testimony that was talking to the previous bill that we just passed, and there being some conflict. Is
I think that you'd have the same type of opposition that would come from 699 and 700.
Right, but specifically, if I remember, there was a statement about the word wasn't used, but potentially being some conflict. Just wanted to know if that was addressed.
Madam Chair, it would be a conflict, I suppose, if you pass one and not the other. You'd have to pass them both together in order for it not to be a conflict. Again, all these issues we're taking a look at comprehensively with that recommendation in mind. I suppose we could put everything in one bill if we wanted to, but it's just a lot. And so we took them separately.
Okay.
Sarah, is that correct? Would I say, was that correct? Oh, Heather, please.
If I may, I think I might, if I understood correctly, I think there might be.
Can you restate your name?
I'm so sorry, Heather Zell with the University of Virginia, here representing Professor Bonnie and our other co-chair and members. I think there may have been an unintended change, and it looked like, and I just noticed last night, so in 700, HB 700, in subsection D on the line 208 to 209, it removed the agreement language for direct MOT, and that wasn't part of what the group discussed. There would still be agreement for that direct version of MOT where somebody is receiving MOT at a commitment hearing, but the recommendation was to remove that from the step-down kind of MOT, and that might be where the conflict is coming up, because it's sort of removing consent, but also we're later talking about consent in 699, but maybe I've misunderstood.
Actually, if I can speak to, my understanding of where the conflict would be, and you can correct me if I'm wrong about this, is that if this bill does not pass, which would remove the requirement that there be agreement for these MOT orders, then you would be in a position where if 699 passed and 700 didn't, that there would be a conflict. But if both passed, there is no conflict.
Or both fail. There would be no conflict if
That was my understanding.
Good, okay.
That's what
My apologies.
That was my understanding.
So we're keeping the language
Keeping
as
it
is?
as is. I mean, if we act favorably, then, with the similar motion, then there would be no conflict. Is that correct?
it still differs from what the recommendation was, but if that's not the conflict that interest with the 699.
Oh, what is it? Tell me.
It is,
What was
it's
your
what I was
recommendation?
saying, and I just sort of inserted my own difference, and it's
Can you say back up?
I'm so sorry, it's more a conflict between what the work group had agreed upon and what's kind of turned up in the language of the bill at this point.
Well, let's fix that.
Okay.
So am I hearing a motion to unstrike the language that is stricken
Yes.
between lines 208 and 209? Is there a second?
Second.
Okay, so it's been moved and properly seconded that we would have a line amendment to unstrike the language in section C in lines 208 to 209. All those in favor say aye.
Aye.
Any opposed? Okay, so that amendment is properly being ordered.
I got it, Bill. But I have, I'll be back right after the bill.
What line is that, sir?
So I'm just wondering, I'm trying to move through this quickly, if we're looking, if unstriking the language which is proposed back, do we also need to look at page 1, line 28 of the C? Because that also strikes the consent from one.
And so we hadn't talked about draft code for the minor
Do you wanna take that,
position.
then we need to take that out as well, that whole section,
Take out
the whole section.
Unstrike it, Bill.
Because that's the only change in that section.
If the attorney could report the second amendment.
So what we're gonna end up with is a substitute to this bill that only includes the language beginning on line 87, that section. And then it will, the only change to that section will be change that is currently on line 178 in C2. Because you're taking out the consent to the direct to MOT, the initial, in the cases where the initial order is directly to MOT, we're taking out the requirement for that type of mandatory outpatient treatment that the person, we're essentially putting back in the requirement for their consent. And if you're gonna do that, you also need to make that change on page 1, since that's the only change in that section at all, the result is the whole section comes back in. So really what you'll have is a bill that just eliminates the consent requirement before step down MOT.
Okay. Is that your motion?
That's correct.
Okay, is there a second? Okay, so it's been moved and properly seconded that, we would make those amendments in the form of a substitute. All those in favor say aye.
Aye.
Any opposed? Okay, so the substitute, will be fixed for us soon.
This does need, yes, it does need to go to the.
And so, Delegate Hope, did you have any, final words? Okay.
No, Madam Chair.
And do we hear from the host? Okay. So is there anyone here to speak in favor of House Bill 700 that would add new information from what we heard, especially to the people that have already spoken to all four?
Yes, briefly. Again, I'm Lisa Daly from Treatment Advocacy Center, and I was a member of the work group. Just wanted to present that there was broad consensus, actually unanimous consensus on the issue that the language requiring agreement prevents the statute from working as it's intended because it creates confusion as to whether it remains in effect if agreement is withdrawn. Prevents an order for those who are good candidates for outpatient treatment due to the lack of agreement, which perversely leads to a lengthening or increase in hospitalization for those who lack insight only. The agreement requirement makes the law statutorily obsolete, as there is actually there's no need for a law that for a person to agree to treatment. And as such, we were in agreement as a work group, and I would like to add my support that this is a provision that would effectuate the work group's decisions.
Thank you. Anyone here to speak in opposition to House Bill 700?
Madam Chair, Colleen Miller from the Disability Law Center. I do think that House Bill 700 stands the chance to do the most damage to mandatory outpatient treatment. We use the word consent, but what we're actually looking for is an individual's cooperation in treatment, and that is the key to the success of any treatment. Just try to imagine without seeking the cooperation of the person being treated, are you asking the treating professionals to hold that person down and shove the medication down their throat? Are you asking them to inject medication over their objection? What exactly are you intending is going to happen if the person is not going to cooperate in the treatment? I believe that mental health consumers universally would tell you that their greatest chance of success is cooperating in their own treatment and believing in their own recovery. And so we would urge you to, I think some of the discussion you've had here has really demonstrated the confusion about making a little change here and a little change there. I think you're gonna be tripping over each other on these different bills. My understanding is that the work that Delegate Hope is referring to is an interim report from this group. It is not a final report. It is not the final conclusions about what needs to be done on this with respect to this program. And I do think that you're going to be kind of stepping in it if you start to make changes before the final report is done. Thank you.
Chair?
Yes,
I'm
Delegate
sorry,
Bell?
let it finish.
Okay.
No, it's okay.
Bottom neighbor with vocal again. Thank you. Clearly, we've heard this morning from people who have gone through MOT who believes it worked for them or helped them. I don't want to disregard that fact. But I want to put on the table the fact that it doesn't work for everyone. And people often know their personalities and what works for them. And we heard earlier too that when someone's invested in their decisions that are made about them, there are better outcomes. So to take away my investment opportunity, my opportunity to invest in my treatment, is to set me up, perhaps, not everybody, but to set Bonnie up,
failure. If I walk into something where my right to make a decision for myself is taken away, where I feel like I'm being punished for having an illness, which is a little bit what this feels like, without being able to say, okay, I do think that might work, let's work with it. I feel like we're setting some folks up for failure in an attempt to provide an opportunity for some folks who think that might work for them. So Hochul opposes the piece about in 700 about taking away my right and others' rights to say I do agree that this is an opportunity for me.
Thank you.
Madam Chair, members of the committee, Bruce Cruiser with Mental Health America, Virginia. Fully respect the intent of the delegate and of the other supporters who have spoken. I think we all want something that's less restrictive than inpatient and jail. I mean, I think that's the goal of everyone. I just would support the comments made earlier at the Disability Law Center that I think we need to complete the study process and not just chip around the edges. To me, the real need is training. Whatever we do, there needs to be full and complete understanding of what the law is. And currently, only a handful of community services boards actually use the statute. And there are a lot of confusion out there. So I would just support the idea of let's complete the study process and do the whole thing in a complete rewrite. Thank you.
Hello again, my name is Jennifer Spangler. I wanted to thank everybody for opposing this, along with myself, as a person who receives services. My treatment is much more meaningful when I'm involved. I also know what works and what doesn't work for me. I've had my illness for 20 years, so I fully know all the medicines that work, the behavioral therapy, the group therapy that works for me. And being put into a mandated outpatient does not make me involved in that, and so therefore, more often than not, my treatment is harmful. And yes, my treatment course has been laid out for me. I know it's gonna be harmful, but I can't resist because I'm gonna be labeled non-compliant because that has other bad consequences. So yes, I'm pinned down and I'm injected with a medication that gives me 3 side effects, that requires 2 more medications, that also give me side effects. And so it's frustrating for me personally to know that people that aren't intimately aware of my needs, and specifically myself, I just really don't think that this type of outpatient treatment is going to be doing what you intended to do. And additionally, I think it's a waste of time if the individual isn't consulted and a waste of money, because these are expensive. Thank you.
Thank you. And any new information?
Yeah, I would like to address this part of the continuum of care. So when you are going through the continuum of care, at the worst part, when you're in crisis, and what these bills help to address, of course it would be great if the patient had insight at the time of his or her illness and could agree to a treatment plan. Unfortunately, because of schizophrenia, 65–70% of people who suffer from the illness are often in the beginning of the illness, have no insight into what their illness is, cannot agree to a plan, will not agree to a plan. So this part of asking for an agreement when a person is in their deepest crisis, although it would be better to have the patient's consent, is not applied to the thousands of people in Virginia who are in crisis without insight. So that's what this addresses. Thank you.
Thank you. Delegate Hope, any last words?
Thank you, I mean, I would just underscore this point. We have 2 tools that we use that we can force people into treatment. We've got involuntary inpatient treatment, which is a big deal, and what we're trying to perfect here is outpatient treatment. The people that this is less restrictive. We could go through we could delay this for years if we want to, and the people that came up behind me opposing this bill would still oppose mandatory outpatient treatment or inpatient. This is a tool to get people the least restricted. We have a tool that's already in our code. I fear more people are being hospitalized on an involuntary inpatient treatment because this tool doesn't work, and that's the problem we're trying to solve to make it work.
Any further questions from the committee?
Madam Chair, a question for the patron.
Yes, Delegate Bell.
So this is still being studied by the Deeds Commission as part of a more comprehensive, or is that not true?
Madam Chair, this is an interim report. We took a look at some of the low-hanging fruit where we could get consensus on, and this is the initial report because we didn't want to wait. We wanted this tool to start being working as soon as we possibly can. We've waited for 2 years on this in study after study. So this was sort of the low-hanging fruit where we had consensus across the board. There are still some other issues that we want to address in MOT, and I expect that's what will happen in the off-season.
And I just, when I heard that, that kind of triggered some things for me, and also hearing that there were no people that will be directly impacted. I don't want to call them patients, but the word that comes to mind is patients that were involved in this specific work group for this interim report. And that.
Yes, so, Heather Zell, University of Virginia, and so I wanna take ownership of the fact that we, dropped our connection from an initial exploratory sort of work group. We had a member from, Vocal with us, who we were very glad to have with us, and unfortunately lost that connection when we really sort of picked up steam in the last, year. That resulted in these pieces. We also had a member from a local chapter of MHAV, Mental Health America Virginia, and the executive director of NAMI at the time. So we expanded also to try and have CSBs. We did what we thought was a thorough job, but we did in fact drop one of our colleagues, a representative from Vogel.
Yeah, and just to the patron, that's a significant piece of the conversation when we're talking about, I think, the process of the MOTs. So that's just my commentary. Any further questions or comments from the committee? Okay, and this, we would have a substitute before us. And if there is a motion, this would need to go to 13th floor. The substitute. Okay. There's been.
As amended?
It's gonna be a substitute.
The substitute has substituted to the appropriate.
Okay, it's been moved and properly seconded to recommend reporting and referring the substitute to the Appropriations Committee. Clerk will open the rolls and members will vote. And that passes 5-1. Delegate Hope, and that concludes we were almost. If we could, if we could, there's someone that's asking for a break here. Delegate Watts, if you want to come on up.
Thank you.
Got really excited about it. House Bill 1351.
And there is, of course, a substitute.
Oh, thank you. Thank you. It's
And this is, the substitute language is important to presentation of the bill. HB 1351, and this substitute language comes from the Department of Social Services, is narrowly focused on the issue of the information that
Delegate Watts, if you could hold on for me 1 second, we're just getting the substitute.
Let me look at it real quick. Okay, so this would, I'm just gonna talk out loud. Okay, so we're still in the same sections, there's no change there. This would take out
copies, 2 or 3, and the director also, there's one more copy here, and also the director has a copy. It was language that he submitted, in fact.
It's just making sure both sides of
Of
all
course,
things
yeah.
have.
Madam Chair. Can I ask a question?
We have not reported the amendments and not everybody has a copy, so if you could give me 1 second.
So the new language would read, in cases in which the evaluation is being completed in the emergency department of a hospital, the person designated by the Community Services Board to complete the evaluation shall consult with staff of the emergency department to obtain information pertinent to whether the individual, can we say meets the criteria for temporary detention?
Pertinent to whether the individual should be subject to a temporary detention order.
I think that would work better if we said pertinent to whether the individual meets the criteria for temporary detention. Yes, I can work on this real quick.
Okay, if there's a motion to go, buy temporarily for,
So moved.
it was moved. It's been moved and properly seconded for this, for House Bill 1351 to go by temporarily. We have an administrative action, at the request of the patron for House Bill 918. Delegate Converse Fowler has requested to strike this bill from the docket. Okay, it's been moved and properly seconded for us to strike House Bill 918. And if we can, clerk will open the roll and then we can record our votes for that. Clerk will close the roll and that passes 6-0.
I can work with this. I can do this in concept if we can tweak the language a little bit from here. Basically what the substitute is trying to get at is cases in which the evaluation is being conducted in the hospital emergency department. The person who's designated by the CSB to do the evaluation would be required to consult with staff of the emergency department to obtain and review information that may indicate whether the person is appropriate for temporary detention. So,
And only if it's available, and then the other, that when it's not being completed in an emergency department, this is belts and suspenders, you don't have to reach out to an emergency department. Again, the bill as introduced was too broad, and this narrows it down to that important medical information, since many people in crisis present to an emergency department. The advancement in medicine often gives us information in some of the chemical tests that might be taken of stress measures within the body that are important for the diagnosis of the crisis that the individual is going through. So as this individual may move into the temporary detention order processes, we wanted to make sure that Community Services Board reached out and got that medical information, because it may be very pertinent of what occurred 8 or 10 hours earlier that may not be something that is as apparent later in the CSB evaluation of the individual. But it keeps the evaluation of the individual in the CSB's hands. It is not an evaluation that is completed by the medical personnel, but you're just making sure that medical information is part of the CSB review and record of determining whether detention order is warranted.
Are there any questions from the committee? Delegate Hope?
Thank you, Madam Chair. Is this a recommendation from the Deeds Commission?
Yes, well, it came out of the work group, and again, the problem with the work group was narrowing the number of people that might be involved in evaluation. So this is a very specific carve-out that looks at the emergency room information. It was not what the work group was trying to go broader than that. This is looking at just one small element.
So if I may ask a question, because I just wanna make sure that I'm hearing things. So when I hear deeds commission, and this can be for anyone at the table, when I hear deeds commission recommendation, I think everyone from the entire deeds commission has fully vetted this. And then I'm hearing work group. So what happens from the work group products as it pertains to the entire deeds commission?
What happened in the last meeting of the Deeds Commission, and I have been on it since its inception, there were a number of specific recommendations that were brought forward that we all agreed on. And then there were recommendations where the work groups that have been formed were not in agreement, but they brought forth what they were looking at. And there were members on the Deeds Commission, there were about three of those issues, as I recall, where because of our ongoing interest in a specific area, said, I wanna take that. And so this was one of those, because I lost I guess she wasn't a constituent, but 35 days of 5 different crises, and she ended up dying in jail, and yet the emergency doctor had twice tried to get an emergency detention order. So this was why I had the heightened concern of the importance of medical records being forwarded to CSB, and CSB being aware of those medical records in any evaluation. And again, given what we now know, I digress to say, my husband had exercised wrong, his shoulder was feeling bad, and then the pain went down. So I spent 6 hours the weekend before in an emergency room of whether or not he was having a heart attack. Well, the fact that you can now chemically tell over a period of time what certain stressors are in the physiology of a person are important aspects of determining whether this person is in fact going through a mental crisis or may have other issues, and CSB would not necessarily have to proceed. Just part of the whole evaluation.
Any other questions for you, Quinn?
Madam Chair?
Yes.
Quick question to the patron. Are there people designated by the CSBs that don't consult emergency departments?
That was certainly the experience that I found just 2-3 years ago. I'm trying to remember exactly when Natasha McKenna got it, but that was what the situation was. This is to make sure that throughout the Commonwealth, if the person has been seen by the emergency room, that medical information is obtained by CSB in their evaluation.
Any further questions? Okay, all those that are here to speak in favor of House Bill 1351, the substitute. Okay, or neutral, wanna just say some things?
Mike Schaefer from the Department of Behavioral Health. The administration has not taken a position on this bill. We do thank Delegate Watts for bringing this bill to our attention. Just to let you know, the chair had asked about the consensus of the SJ 47. 2 bills that came out of SJ 47, Senator Barker and Delegate Ayer are doing an actual study on how do we expand the number of people who can do these temporary detention orders. We felt Delegate Watts' bill was a little premature, and it opened, as she said, the door a little too wide. We appreciate her feedback that maybe there are cases where the CSBs aren't consulting with the ED, and so this bill just tightens that up to make it affirmatively